Let me thank Dr. John sir for organizing today's meet, and thanks to Team Cipla for the support. Polyarteritis nodosa is the topic today. A very good evening to all of you. We know the Chapel Hill Consensus Conference, where we have medium vessel vasculitis, large vessel vasculitis, and small vessel vasculitis due to immune complex and ANCA-associated small vessel vasculitis also. So polyarteritis nodosa is mainly a medium vessel vasculitis like Kawasaki disease, which is a necrotizing vasculitis of medium arteries without glomerulonephritis or vasculitis in arterioles, capillaries or venules and not associated with ANCA. So it is a medium vessel vasculitis. So the initial description of disease was given by Carl Surfoot of Gunsbach, who was a 27-year-old tailor who arrived on 4th March 1865 at 10 a.m. in the internal medicine clinic at the University of Freiburg. And his first impression of Pan was like this. The patient was one of those patients for whom one can already give the prognosis before the diagnosis. The first impression was one of a lost of soul whose few remaining days are numbered. So this was by Adolf Kussmaul in 1866. He had published that. And another initial description of disease by Professor A. Kussmaul of this unexplained disease of polyarteritis nodosa was like this. This is German. I am not well versed in German. It was in 1866, which Professor Kussmaul has told about this disease. The epidemiology of polyarteritis nodosa, the incidence is 0.7 per 1 lakh, prevalence 6.3 per 10 lakh inhabitants in UK, and in France it is 34.8 per 10 lakh inhabitants. The incidence decreased concomitantly with HPV vaccination and hygienic measures, but recently PAN without HPV infection is also increasing. So etiologies include idiopathic virus, HPV related, HCV related, HIV, it is very rare. Co-infections with HPV, HCV, parvovirus B19, Epstein-Barr virus, and deficiency of adenosine deaminase 2 or DADA2. So what are the characteristics of polyarteritis nodosa? It's more common in the males with median age 51 years. You have most commonly the constitutional signs which predominate, as you can see, followed by neuropathy, followed by cutaneous, followed by gastrointestinal, followed by HTA is hypertension arterial, which is a French term, which simply means high blood pressure. Testicular, eyes, heart, CNS, and lungs, it is 0. So there is lung sparing, which is very important to differentiate from other causes. So general signs and symptoms include fatigue, fever, body ache, joint pain, weight loss, and new onset high BP. So this is the most common symptom, which is constitutional, which includes fever, malaise, weight loss, neuropathy, mononeuritis, multiplex polyneuropathy, which is 75% of the cases, arthralgia or myalgia in 60% of the cases, cutaneous you have 50% can have livedo-reticularis purpurea ulcer, renal disease, elevated creatinine hematuria. Glomerulonephritis is not seen in PAN, but HBV, HCV, yes. Gastrointestinal symptoms, abdominal pain, rectal bleeding, 40% of the cases. New onset of hypertension, respiratory manifestations, which include nodules, cavities, infiltrates, CNS, you can have stroke, orchitis, cardiac involvement, and least is cardiac and peripheral vascular disease, which includes claudication, ischemia, and necrosis. So coming to the ACR classification, the 1990, they have mentioned 10 criteria, out of which 3 or more are required for classification as PAN. And these criteria include weight loss more than 4 kg, libido reticularis, testicular pain or tenderness, myalgia, weakness or leg tenderness, mononeuropathy or polyneuropathy, diastolic blood pressure more than 90, elevated blood urea, nitrogen or creatinine, hepatitis B virus infection, arteriographic abnormality, biopsy of small or medium-sized artery containing neutrophils. So more than 3 of the criteria are there. The sensitivity is 82% and specificity is 86%. Now coming to, that was in 1990. So in 2008, the Arthritis Rheumatology Journal, Heidegger has published a negative criteria also, which include a positive ANCA, which is a negative criteria, asthma, glomerulonephritis. So PAN, there is no glomerulonephritis. then ENT manifestations and cryoglobulinemia. So you have to look for other vasculitis if these criteria are present. And the positive criteria included HBV antigen or DNA in serum, mononeuropathy, and arteriographic anomalies. So, what is the pathophysiology of ANCA? We know ANCA is a negative, ANCA negative necrotizing vasculitis. PAN is an ANCA negative necrotizing vasculitis. There is fibrinoid necrosis of the media, thrombosis, perivascular inflammation containing polymorpho nuclear cells, ischemia, and necrosis of affected organs, which lead to the clinical manifestations. So, what are the key aspects of diagnosis? Use of abdominal imaging, CT or MRI in patients with signs or symptoms. Use of biopsies, deep skin biopsy, nerve or muscle biopsy, blood tests. Most often the autoimmune test is negative. You can have an elevated blood cell count, anemia. Maybe in evaluation of a chronic hepatitis B or C, the pan turns up. So this is a kidney arteriogram in polyarteritis nodosa. In large vessel polyarteritis nodosa, you have the kidney audiogram showing a small arrow show the microaneurysm and the large arrows show the abrupt cutoff of small arteries. Again, this is a very clear CT mesenteric angiogram of a 72-year-old male patient who presented with acute abdominal pain and rectal bleeding, and it shows a large hematoma in the upper abdomen from a ruptured aneurysm arising from an inferior pancreatic duodenal artery branch and multiple small aneurysms of SMA and several other intra-abdominal arteries. And this 3D CT shows innumerable microaneurysms as in the arrow, which and arising from multiple branches of SMA and areas of luminal narrowing by the dashed arrow, consistent with polyarteritis nodosa. And coming to the biopsy, this is a light microscopy renal artery in muscular of a small muscular renal artery in pan. There is diffuse inflammation of adventitia, marked thickening of inner layers by loose connective tissues. The lumen is narrowed significantly, and involvement of vessel this large is unlikely in microscopic polyarteritis or in GPA. So the skin changes in pan. You can have a pallor, digital ischemia, gangrene, cutaneous pan with tender subcutaneous nodules, ulcers with necrotic base, livido reticularis, net-like reddish discoloration, which is highlighted here. So cutaneous pan and systemic pan are the various types of pan. Cutaneous pan is considered a subset of pan, and it is limited to skin only and is usually a non-severe disease, not a severe disease. And the progression to systemic disease is very rare. Systemic pan, there is internal organ involvement. There is kidney involvement, muscle, nerves, GI tract, joint inflammation, but systemic pan also can affect skin. The organ systems affected by pan include the brain, heart, gut, kidneys, nerves, and typically it does not involve lungs. So you have the polyarteritis nodosa. The left image shows fibrinoid necrosis with acute inflammation. The right image shows concentric inflammatory inflammation with vessel wall thickening. Here there is transmural inflammatory infiltrate involving the entire vessel wall, fibrinoid necrosis, especially in the right side. The homogeneous eosinophilic pink necrotic material in the vessel wall. There is a concentric conine skin appearance or target skin appearance here. This is due to the intimal proliferation and chronic inflammation. There is luminal narrowing secondary to wall thickening and inflammation. And here you can see multiple small aneurysms along medium-sized arteries, which gives us like a string of bead appearance and rotating segmental dilatation, microaneurysms, and narrowing. It is due to the transmural necrotizing inflammation. The vessel wall is weakened and there forms an aneurysm. So pan usually spares the small vessels and the capillaries, hence there is no glomerulonephritis, but renal artery involvement and hypertension is there. Clinical characteristics and outcomes of PAN. This is a global PAN study. Over 30 years, they had 358 patients with PAN, of which fibrinoid medial necrosis, there were 11 patients, deficiency of adenosine deaminase 2, 16 patients, HBV-related PAN, 22 patients, pediatric onset disease, 25 patients, systemic or cutaneous PAN contributed majority. The time to first relapse and survival was the first year, the probability of first relapse was 18.8, fifth year 36%, and 10th year 49%. And the survival was 10th year, it was 91%. So the mortality predictors in global PAN study, they were age more than 65 years, patients with GI manifestations, serum creatinine more than 140 micromole per liter, and patients with CNS involvement. All these contributed to mortality. The therapeutic management of PAN, prognosis and therapeutic management. In the 260 polyarteritis nodosa and 82 eosinophilic granulomatosis polyangiitis patients, identification of factors with poor prognostic factors. Both you have an FFS score or five-factor score, and you have certain points. The five-factor score had proteinuria more than 1 gram per day, serum creatinine more than 140, GI tract involvement, cardiomyopathy, and CNS involvement. If the FFS score was 0, you induct with glucocorticoid and you maintain with glucocorticoid over 18 to 24 months. And if the FFS score, either of any of these factors are present, one or more are present, glucocorticoids, you can give pulse or glucocorticoids also, plus cyclophosphamide is required for 6 to 9 months, followed by glucocorticoids plus azathioprine or methotrexate as maintenance for 8 to 24 months. So this is the five-factor score. Polyarteritis nodosa, the conventional regime. This is a 10-year result of prospective Trispan trial, including PAN and MPA with poor prognostic factors. And this is the relapse-free survival. This is PAN and this is microscopic polyangiitis. The patients diagnosed between 1963 and 2005 after follow-up of 16 months. The relapse of vasculitis in non-HBV PAN was 22%, and regarding death, 25% of the patients had an HB who had 25% of the patients had death, which was related to an HBV related polyarteritis nodosa. So, what are the strategies in case of a refractory or relapsing polyarteritis nodosa? So, this is another European collaboration on the off-label use of relapsing or refractory PAN. 52 patients they studied with median age 51 years, and the data suggested that TNF alpha blockers and the tocilizumab could achieve higher remission and glucocorticoid sparing than other biologics. Now coming to DADA2 testing, deficiency of adenosine deaminase 2. Adenosine deaminase 2 is an enzyme that aids in development and differentiation of different immune cells, present in young adults, and it includes features like fever, skin ulcer, reticularis, neuropathy, elevated inflammatory markers. It is rare in adults, and treatment with anti-TNF alpha therapy is better. So, DADA2 related PAN is an autosomal recessive disease caused by biallelic mutations in adenosine deaminase 2. Clinical manifestations include fever, early onset lacunar stroke, libido racemosa, nodular vasculitis, and other features include portal hypertension, immunodeficiency, red cell aplasia, and neutropenia. So there is imbalance in differentiation of monocytes towards pro-inflammatory M1 type, and 6.8% of the adults with idiopathic PAN have rare missense variants in ADA2. So the treatment considers this: you replace the ADA2 exogenously, TNF alpha blockers, and allogenic hematopoietic stem cell transplantation in case of profound immunodeficiency. So this is again an open label study of DADA2, very rapid clearance of exogenous ADA2, efficacy of TNF alpha blockers without any safety concerns were given. Before anti-TNF initiation, in patient months of 2077, the number of strokes were 55 and the recurrence rate was 0.025. And after TNF initiation, the number of strokes was 0 after 733 patient months. So after anti-TNF alpha, there was no stroke at all, published in NEGM in 2019. Coming to the types of cutaneous polyarteritis nodosa, it involves the deep dermal and hypodermal arteries. So nodules, ulcers, livedoreticularis, urticaria is there. There is no visceral involvement. It has a chronic and relapsing cause, and rarely it moves to a systemic pan. Treatment is based on the benefit and risk. You give NSAIDs, colchicine, hydroxychloroquine, dapsone, glucocorticoid, lower dose 0.5 to 1 milligram per kg per day, and conventional synthetic disease modifying anti rheumatic drugs, methotrexate, azathioprine, cyclophosphamide. Kidney transplantation. Few data exist concerning the outcome of patients with pan and end-stage kidney disease who undergo kidney transplant. Among 112 patients with pan reported in the ERA-EDTA registry, transplantation was associated with significantly lower patient and first cadaveric allograft survival rates compared with those diagnosed with other kidney diseases like glomerulonephritis, interstitial nephritis, or toxic nephropathy and cystic kidney disease. So 13% of the graft failures were reportedly due to recurrent disease. So treating pan, steroids for the initial treatment, you start at 1 milligram per kg dose, and for the first 3 to 4 weeks, and then for the next 2 months, you taper the dose to 20 milligram, and thereafter you decrease by 2.5 milligram, very slow tapering. You can give pulse steroids also for initial 3 days in severe disease, cyclophosphamide for severe disease, methotrexate, azathioprine, IVIG, mycophenolate mofetil. Case reports are showing with the DADA2 anti-TNF therapy and this anti-TNF alpha therapy, then rituximab and Acmera, Xeljanz, but the data is very sparse. Antiviral therapy with hepatitis, you treat the underlying hepatitis B and hepatitis C with antiviral therapy. So take home messages: polyarteritis nodosa is an ANCA anti-neutrophilic cytoplasmic antibody negative necrotizing vasculitis. The incidence decreased with HBV vaccination, but without HBV infection also there is PAN. Consider deficiency of adenosine deaminase 2 in case of the patient in the following: young age or multiplex family, early onset lacunar stroke, relapsing cutaneous involvement. Therapy is still based on this conventional synthetic DMRDs, except for DADA2, where you have the TNF alpha blockers.
Actually, very less literature on this, and nothing is very concrete. As of now, we don't even have definitive criteria to diagnose. You need to have a very high index of suspicion to even think about it, unless you find somebody with hypertension and then you do an angio and then you pick up the typical radiological feature. Many times it is said that, especially in younger individuals, there could be dissection of the artery, dissection of the renal artery that can actually mimic an acute abdomen, like an acute appendicitis. So only the hypertension would give you a clue. So there could be some atypical presentations also. Yeah, go ahead, John.
Yes, a few questions we'll have from PG point of view.
Yeah.
The first question: which of the following describes the primary mechanism of renal failure in classic polyarteritis nodosa? Option A, ischemic damage due to stenosis and arterial occlusion. B, necrotizing glomerulonephritis and capillary involvement. C, direct viral invasion of the renal tubular cells. D, amyloid deposition within the renal medulla.
Right. So it's very clear here that the option A, ischemic damage due to stenosis and arterial occlusion, is the right answer. Classic PAN is a medium vessel necrotizing vasculitis. It spares the small vessel, so the glomerular capillaries are not involved. Hence, there is no primary glomerulonephritis. Why does renal involvement happen? It happens because of segmental inflammation of the medium-sized renal arteries. There is luminal narrowing. There could be thrombosis and microaneurysm formation, which leads to renal ischemia and infarctions. So this leads to classically renovascular hypertension and progressive ischemic renal injury. Necrotizing glomerulonephritis is seen in ANCA vasculitis. In fact, a negative ANCA would if you have some skin lesions and you don't have a glomerulonephritis and you run an ANCA and the ANCA is negative and there's no proteinuria, then it rules out to practically a glomerulonephritis, and PAN typically does not involve the glomerulus. Of course, the direct viral invasion is not the mechanism, though PAN may be associated with hepatitis B, but there the injury is only immune mediated. And the last one, amyloid deposition, happens in chronic inflammatory states like rheumatoid arthritis or ankylosing spondylitis or tuberculosis, where you have what is the AA amyloid deposition, which classically presents as proteinuria, massive proteinuria. So this chronic PAN is not a chronic inflammatory state. So if you want to sum this up, I will say renal failure in PAN is due to medium vessel vasculitis causing ischemia and not glomerulonephritis.
Yes, sir. Shall we move to the question number 2?
Yes.
In the context of renal imaging for polyarteritis nodosa, what does the finding of a wedge-shaped, low attenuated lesion on a CT scan typically indicate? Option A, active glomerulonephritis. Option B, renal cell carcinoma. C, polycystic kidney disease. D, renal infarction.
So here again, it's very obvious. The correct answer is renal infarction. In PAN, the pathology targets the medium-sized arteries. This leads to arterial narrowing and thrombosis, and there is segmental ischemia. So on CT imaging, a wedge-shaped, low attenuated lesion is very classic for renal infarction. The wedge shape reflects the segmental arterial supply. That is what we call the end artery pattern, with the apex pointing towards the medulla and the base towards the cortex. So it's like a triangle. And why this matters? Because it's a direct radiological correlate of ischemic injury and not a glomerular disease, often seen along with multiple infarcts or microaneurysms. Again, in active glomerulonephritis, this gives a diffuse or patchy enhancement, not wedge-shaped infarcts. RCC is typically a solid enhancing mass. It is not wedge-shaped. And of course, polycystic kidney has got the typical multiple cysts. There would be no focal wedge deficits. Again, to sum up, I would say in PAN, a wedge-shaped hypodense renal lesion on CT with the base towards the cortex and the apex towards the medulla would indicate a segmental renal infarction due to medium vessel vasculitis.
Thank you, sir. Shall we move to the next?
Yeah, sure.
For a patient with newly diagnosed active severe PAN, the 2021 ACR-VF guidelines conditionally recommend which induction regimen? Option A, methotrexate and low-dose prednisolone. Option B, cyclophosphamide and high-dose glucocorticoids. Option C, azathioprine and plasmapheresis. Option D, glucocorticoids alone for 6 months.
Right. So as I discussed earlier, for a patient with newly diagnosed active severe PAN, the option would be B, cyclophosphamide and high-dose steroids. So here we give an induction therapy with high-dose steroids and cyclophosphamide for remission induction. See, severe PAN involves organ or life-threatening disease. It could be renal ischemia, mesenteric ischemia, neuropathy. So it requires rapid disease control with potent immunosuppression. So cyclophosphamide reduces relapse and improves survival compared to steroids alone. Methotrexate and low-dose prednisolone, option A, is used in non-severe disease, not in severe PAN. Azathioprine with plasmapheresis, azathioprine is maintenance, and plasmapheresis only in very, very selective case, probably hepatitis B PAN. Those incidences have come down largely because of one vaccination and also because of the treatment available for hepatitis B. And steroids alone again is wrong because it's inferior for severe disease. There's a high relapse risk. So to sum it up, I would say severe pan, cyclophosphamide plus high dose steroids for induction. Methotrexate is only for non-severe disease.
Yes, sir. So next question, shall we move?
Yes.
What common lab findings helps distinguish polyarteritis nodosa from ANCA-associated vasculitis like microscopic polyangiitis? Option A, high titers of ANA, antinuclear antibodies. Option B, elevated C-reactive protein. Option C, the absence of anti-neutrophil cytoplasmic antibodies. Option D, low serum complement levels.
Right, here again the answer would be the absence of ANCA. The correct answer would be option C. A key laboratory distinction between PAN and MPA is PAN is typically ANCA negative, MPA is usually ANCA positive. Of course, ANCA is now done, it is advised to be done by ELISA, which will give it as MPO3 ANCA or PR3 ANCA. So this aligns with the Chapel Hill Consensus Conference definition, which emphasizes that PAN involves medium vessels, lacks ANCA association, and lacks glomerulonephritis. Of course, ANA is a very non-specific thing. It's seen in many connective tissue disorders. Of course, it's a very highly sensitive test to pick up lupus, nearly 95% sensitivity when used with the Hep2 cell line. CRP can be elevated both in PAN and MPA because it's a non-specific inflammation marker. And low complement levels may occur with immune complex disease, not a key discriminator here. So PAN is a classic ANCA negative vasculitis, unlike MPA, which is ANCA positive.
Yes, sir. Thank you, sir.
Yeah.
Shall we move to the next question, sir?
Yes.
Why is a deep skin biopsy preferred over a superficial punch biopsy when diagnosing suspected cutaneous involvement in polyarteritis nodosa? Option A, the disease primarily affects medium-sized vessels located in the deep dermis and subcutis. Option B, deep biopsies are required to identify the presence of ANCA. Option C, superficial biopsies only capture capillary involvement, which is a hallmark of PAN. Option D, superficial biopsies are more likely to show non-specific granulomatous inflammation.
So here again, as we discussed earlier, the right answer would be option A. The disease primarily affects the medium-sized vessels located in the deep dermis and subcutis. So in PAN, the vasculitis targets medium-sized vascular arteries. In the skin, these vessels are located in the deep dermis and subcutaneous tissue. Therefore, a deep incisional bar excisional biopsy is required to capture these vessels. A superficial punch biopsy often samples only the epidermis and the superficial dermis and misses the diagnostic lesion. The other options are incorrect because ANCA detection is done by serology, not by biopsy. Capillary involvement is again wrong because PAN spares the small vessels, because this typically describes ANCA vasculitis. And granulomatous inflammation is not a feature of PAN. It is seen in GPA, granulomatosis with polyangiitis. So the right answer would be PAN requires a deep skin biopsy because the pathology lies in the medium vessels of the deep dermis, bar subcutis, where the superficial biopsies may miss it. Yes, John.
Thank you, sir.
Yeah.
So next question, which histological feature is a major point of distinction that separates PAN from microscopic polyangiitis? Option A, absence of small vessel capillary or venule involvement. Option B, formation of granulomas. Option C, the presence of T lymphocytes. Option D, presence of fibrinoid necrosis.
Right. So the histological feature, which is a major point of distinction for PAN, is the absence of small vessel involvement. So the option A, absence of small vessel, that is the capillary or the venule involvement. The defining histological difference between PAN and MPA is PAN involves medium-sized arteries, sparse small vessels, no glomerulonephritis. MPA involves small vessels, there is capillaritis and necrotizing glomerulonephritis. So this distinction is central to the Chapel Hill Consensus Conference classification. Why the other options are incorrect? Granulomas are seen in GPA, not in PAN or MPA. T lymphocytes are a non-specific inflammatory finding. And fibrinoid necrosis may be seen both in PAN and MPA. It doesn't help to distinguish. So the answer would be medium-sized vessel disease. PAN is a medium-sized vessel disease without small vessel involvement. MPA is a small vessel vasculitis with glomerulonephritis.
Thank you, sir. Shall we move to the next question, sir?
Yeah, sure.
Which finding on a renal angiogram is highly suggestive of polyarteritis nodosa? Option A, multiple small aneurysms and irregular stenotic lesions. Option B, diffuse thinning of all glomerular capillaries. Option C, pruning of peripheral pulmonary arteries. Option D, smooth long segment narrowing of the aorta.
And I think Vidya discussed this as the first question.
Yes.
So the correct answer here is multiple small aneurysms and irregular stenotic lesions. So this is a classic imaging hallmark. On renal angiography, the signature finding is that multiple microaneurysms, which is the rosary pattern or the string of bead appearance. So this is because of segmental arterial narrowing and irregular stenosis. Why this happens? This happens because of transmural necrotizing inflammation of the medium-sized arteries, weakening of the vessel wall that leads to aneurysm formation, and healing and fibrosis, which causes the irregular stenosis. Why the other options are not right? Diffuse capillary wall thinning, PAN spares the glomeruli, number one. Pruning of pulmonary arteries seen in pulmonary hypertension, not in PAN. And smooth long segment aortic narrowing is suggestive more of Takayasu arteritis rather than PAN. So the renal angiogram in PAN shows microaneurysms with irregular stenosis. The string of beads appearance, a very characteristic diagnostic clue.
Thank you, sir.